Welcome to the webinar, The Implant-Retained and Supported Overdenture Prosthesis. The lecture will be presented by Ibrahim Duquam, DDS, MS, FICD, and we will begin shortly. And with that, it is my distinct honor to introduce and welcome back Ibrahim Duquam, DDS, MS, FICD. Dr. Duquam is a professor of prosthodontics and the chair of the Department of Restorative Sciences at UNC Chapel Hill Adams School of Dentistry. He completed his DDS degree at the University of Jordan and earned an MS in prosthodontics from UNC Chapel Hill in 2008. He is a fellow of the International College of Dentists and the ADEA Leadership Institute. A published author, Dr. Duquam lectures nationally and internationally about all aspects of prosthodontics, aesthetics, and dental implant therapy. And with that, I get to say, take it away, Dr. Duquam.
Thank you so much, Jessica. Really appreciate the kind introduction. Good evening, everybody. Hope everybody's doing well and enjoying this early fall day and evening. It's my pleasure today to talk about a very important topic, especially when it comes to tooth replacement therapy, utilizing dental implants for removable implant overdentures. Just move my slides here. So my objectives for today were to understand the impact of edentulism on anatomy, physiology, and systemic health in general. Try to comprehend the removable options for the management of complete denture patients utilizing dental implants, and understanding the evolution of treatment options, the materials, the workflows that are available for us today in this very important, very exciting therapy for our patients. So first, I want to start by saying that this is extremely important because we live in an age and time where actually we're experiencing signs of a global aging. They call it call us the silver nation now, moving more towards people living longer and create new opportunities for us, but also some challenging, particularly from a healthcare standpoint. There are an estimated 857 million elderly people. That's people aged 65 or older worldwide in 2025. This represents about 10% of the global population. This number has doubled since the 1950s. So over the last 3/4 of a century, the number of elderly people, doubled. And again, as I mentioned, this creates a lot of opportunities, but also challenges from healthcare standpoint. So the projections indicating that it will nearly also double to 1.58 billion by 2050, so within the next quarter of a century. So again, there are a lot of people who would require our services and our needs. Why this is important for us? It's because according to recent research data up to 2021, approximately about 353 million people worldwide were completely edentulous. And this number is expected to continue to rise. So yes, we made a lot of great advancements. Actually, the rate of edentulism is reduced than what it was before, but the number of edentulous people, because of the population growth, is going to continue to rise. So these are patients who would require treatment, would require functional prosthesis that affects and impacts their quality of life. So again, while precise data for 2025 is not yet available, the forecasts show that the total number of edentulous patients will continue to grow in the future moving forward. So how did we treat these patients traditionally? Obviously, we have been doing complete dentures for over 100 years. It's an amazing prosthesis. It can be done very, very nicely, like what you see in this picture with tending, with full extension, and believe it or not, it works. It works for the most patients, but it has some inherent shortcomings that comes with the way the patient adapts to this type of treatment, moving from their own teeth that are aesthetic, functional, to actually a prosthesis that they have to adapt to. There are a lot of changes that they have to go through for them to be able to function and speak well in these type of restorations. So what are some of the problems and the problems with conventional dentures in general? Lack of retention is a big one. More than 50% conventional, particularly mandibular dentures, have problems with retention and stability. We know this from a lot of works and studies that were done in the last century. Physiological ridge resorption, particularly in the mandible. At least about zero point 0.4 millimeter of mandibular anterior vertical resorption occurs um, each year after the loss of teeth. So obviously that's affected denture base, and by virtue will affect the retention and the stability and the functionality of the denture. Some of the problems with the maxillary denture. Generally, patients do much better with maxillary denture versus mandibular denture, but sometimes it's unrealistic functional prosthodontic experiences that the patient may have or expectations. They can have depend on the extension or the palatal extension of the denture, have hyperactive gag reflexes with the removable prosthesis, and a lot of patients may have psychological inability to wear or to adapt to a denture. So what are the solutions that we can have to improve the quality of life for these patients? Traditionally, we looked at increasing the tissue, the supporting tissue volume, whether that by ridge augmentation, whether that by surgical extension therapies such as alveoloplasty. Um, Look at tooth-borne overdentures. So what you see here in this picture is a combination of between tooth-borne and implant-supported overdenture. So we can utilize teeth with attachments. We did that before dental implants to support these prostheses. And definitely now we have dental implants, which is in my mind one of the best inventions that impacted dentistry with local anesthesia within the last 60 years or so. We can utilize that in removable fashion, such as the overdenture prosthesis, which what we will discuss today in detail. Also, fixed dental restorations, fixed dentures, if you will, whether in hybrid fashion or even in fixed reconstruction with dental implants. And hopefully we can discuss that in future webinars. But the advantages of the implant-supported or retained overdenture, it improves the retention and the stability. It improves the masticatory function for the patient. It can preserve, to a certain extent, bone preservation, particularly in the anterior segment of the mandible where, or the maxilla where the implants are placed. And certainly it will improve the patient satisfaction and their quality of life. Obviously, it will reduce the need for denture adhesives because it improves the retention and the stability of the dental implants. So what are the consideration of implant support over denture, particularly in the mandibular arch? The things that we have to look at is, do we have sufficient bone volume and height to place dental implants? And that's mainly looking at regular size implants. Those are the 3 millimeter or wider implants in conventional fashion. And sometimes we utilize mini dental implants, either in interim or permanent manner, when there's insufficient volume height and volume for regular size dental implants. Also, it's very important to consider that we need to have acceptable interarch space, the vertical space from where the occlusal surface or the incisor surface of the teeth to the platform of the implant. We need a minimum of at least of 5 to 6 millimeter to be able to accommodate the attachments, the abutment, and also the prosthetic teeth and the denture and the acrylic part of the denture itself. That's particularly for locator abutments, which has a little bit lower profile than other type of attachment. But generally speaking, just for take it easier to remember, I would call it the 10 millimeter rule. You would need to have about 10 millimeter between the platform of the implant to where the incisor or the occlusal surface of the teeth, but a minimum of 5 to 6 millimeter. And if we can't accomplish that, sometimes we may have to consider alveoloplasty to create the space so we don't run into a problem where the denture is thin, or we have to over open the patient, and that can result in other problems from aesthetic or even functional standpoint for the patient. So this illustration show pretty much exactly how much the spacing we need, whether that's about 2 millimeter for the attachment, the, the space needed for the denture teeth, the attachments, the housing that goes in the denture base. All of that would require about 10 millimeter or so of interocclusal space to be able to accommodate for the overdenture prosthesis. Now, some of the biomechanical principle to understand for overdenture. Uh, Normally, because this is a removable prosthesis, even though you have the attachment, we'll still have movement that happen within the prosthesis. And that movement happen in different rotational axes. So how many implants we need, what the distribution of the implants, it depends on the type of movement that we're trying to prevent. So we're going to discuss what these rotational axes is and how they are impacted by various number of dental implants, the number of dental implants that are recommended for both arches, mandibular and maxillary, the alignment, the location of the implants, and the types of the retentive mechanisms. But the prosthesis can move in multiple directions. It can move in an anterior-posterior direction, front to back, which is probably the most important rotational axis that we think about. But also the prosthesis moves side to side. That's mediolateral movement, and in the sagittal section, going up and down. And the presence of dental implants to provide support and retention through the various retentive mechanisms can offset some of these movement that happens during the function of the denture. Also, particularly in the mandibular flexes, and that results in an inherent movement within the prosthesis, particularly with fixed dental rehabilitation, but also removable. It has effects. What happens over time, this may result in wear of the uh, components inside the denture that require frequent replacement. Over time, also, it may result in wear on the abutment itself. So this is something that you need to discuss with your patient when you put them in those type of prosthetics. What's the maintenance? You buy a car, they will tell you about the maintenance protocol. Here's the same thing. Okay, I have this prosthesis. Maybe you'd expect to replace this attachment at least once a year, and that's just the nylon part of the attachment. And maybe over 5 to 6 years, you need to replace the abutments. There is a cost involved, there is a maintenance involved, the patient has to be prepared for those type of treatment and adjustments needed. Now, number of implants. Believe it or not, the minimum number of dental implants that can be utilized for overdenture is a single implant placed around the midline. And if you think about this prosthesis, yeah, it's going to improve retention and stability over no implants, but still, this prosthesis will allow pretty much movement in all three different axes. So in the sagittal movement, the anterior posterior and side to side movement will still happen with the implant overdenture. Now, when we have two implants overdenture, uh, can minimize the movement. Still, we have the anterior posterior movement, side to side and up and down movement, but to a lesser extent. What's the best position for two implant overdenture? It will be in the lateral incisor position. A lot of us like to place them in the canine position. Actually, by doing that, you increase the anterior posterior rotation around dental implants. So it's better to place them in the lateral incisor position, assuming there is enough bone volume, there's enough attached gingiva in that area. But again, it still will allow AP rotation, and again, retentive devices will prevent the sagittal rotation, and the location of prosthetic teeth is very, very important. Again, we're assuming a normal class 1 occlusion. We like them to be in the lateral incisor position. Actually, for the mandibular overdenture, my preferred design would be to place 3 implants. I know it's probably 4 implants can result in more retention and stability, but for me, it might be a little bit overkill for removable prosthesis. If I'm placing 4 implants or more, I'm probably thinking more about a fixed prosthetics, unless it's the type of patient where I trying to safeguard against losing dental implants, or maybe bone quality and quantity may dictate that. Also, or I want to utilize a bar. But generally, for solitary attachment, meaning single attachment, I like the 3 implant design of overdenture. So I will move the 2 distal implants to the canine position. I place a 3rd implant anterior to that around the midline. So this will help tremendously with that anterior posterior rotation. It will probably provide you with very similar retention and support as a 4 implant overdenture, prevent movement in all different directions. What you will notice though is that middle implant, because of the prevention of that anterior posterior movement, will be the one that would require replacement of the insert or the attachment insert the most. It's going to wear out faster. And of course, you want that prosthesis to be very well adapted to the posterior segment of the mandible. Sometimes you may actually have to reline the denture frequently or utilize techniques similar to alternate cast of what we use it with, like Kennedy class 1 mandibular partial denture. Okay, so you treat it almost like a mandibular partial denture. Also, for implant overdenture, been discussed and recommended. You will have 2 implants in the lateral incisor position, 2 implants in the premolar or first molar side. They are widely spread. They prevent retention in all different direction. It is excellent prosthesis, very, very stable. But as I mentioned, if I'm placing 4 implants, that's widely spread. I probably be thinking more about fixed denture. Or you can have a hybrid with higher profile attachment that can be more fixed, but still removable, where the patient can remove the implants for better maintenance and cleaning around the dental implants, which we will discuss later in the presentation. When we talk about the maxillary implants, the dynamics here are different. So the minimum number of implants that we should consider for a maxillary overdenture should be at least 4 implants that are widely distributed. So what you see here is, if I'm trying to avoid the sinuses, placing the implants or the anterior area, I mean, of course, it's going to help with retention and stability, but we're still going to have a lot of rotation, a lot of wear on the attachment. So I rather have this type of a design where the implants placed in the canine position, premolar position, maybe lateral incisor, and premolar position. They are more widely spread and provide very, very good retention. Why 4 implants versus the 2 as minimum that we consider for the mandible? It's because of the bone quality. The bone in the maxilla is much, much softer. You probably have more biological complication happening for the maxillary arch, including even implant fracture, bone loss, periimplantitis. So maximizing the number of implant and the distribution would help with all of this. So again, number of implants in the mandible, 2, 3, or 4. I'm a big fan of the 3 implant overdenture. Provides a lot of enhancement over the 2 implant overdenture in my mind, with a little bit minimal increase in cost, if you will, and not too much in the maintenance. Now, there are indications in general for the more than 2 implants overdenture. That generally, if a patient has a dentate maxilla. So notice that if you don't do that, you're going to have more forces coming from the opposing arch, the mandibular arch, resulting in more bone resorption, flabby ridges. So you will consider to offset that by increasing the number of the dental implants. Also, you have to consider the size of the implants. So if the implants are less than 8 millimeter in length or less than 3.5 millimeter in width, you try to increase the number of implants in these situations. Patients with sensitive mucosa, so you try to make the denture to be implant supported versus retained. The difference is how much of that retention and support coming from the implants versus the ridge or the soft tissue. By increasing the number of the implants, increasing the anterior posterior spread or the distribution, you will have more implant support versus tissue support, and that helps with patients who have sensitive mucosa, high muscle attachment, sharp mylohyoid ridges, in the maxilla, large V-shaped ridges or extreme gaggers, because you can actually eliminate that palatal extension by having an open palate design, particularly if you run a support framework with from metal or different types of copolymers that you can use nowadays. And of course, patients who have high retention needs. So that's consideration for having more number of implants. For the maxilla, again, as I mentioned, you would like to avoid 2 implants. 4 implants that are widely spread, similar to what you see in this picture, is what is pretty much preferred. They are broadly distributed. They span more anterior posterior, provide good retention and minimize rotation on all different directions. Another point of discussion is, should we consider solitary attachment, single attachment implants, or should we splint those implants together with a bar? And there are actually 2 schools of thoughts here. One calls for simplicity, better hygienic principle with the solitary attachment. The other one talks about cross-arch stabilization, preservation of bone around dental implants. Really, if you review the literature and you look at various studies and systematic review, you'll notice that actually there is no difference between solitary attachments and overdenture on bars as far as the health and the survival of the dental implants. Complications are actually less with single implants versus bar prostheses, which are associated with more tissue inflammation and uh, some biological complications. So here's Sadowski in 2007 published a systematic review, and he found that unsplinted dental implants actually require less space, 10 to 11 millimeter versus 13 to 14 millimeters, so they are easier to manage. There is no difference when it comes to mean bone loss. The bars should be used in cases where you have excessive implant angulation, you don't have parallelism between the dental implants, which affect the path of insertion for the prosthesis, but also its ability to retain the denture properly, so you can correct some of these misalignment of dental implants with a bar, but it's also associated with more hyperplasia. And patient will be more equal satisfied with both type of retention for this treatment. Um, so for this type of overdenture, palatless design, which means open palate with a supported metal framework, is preferred. And according to the systematic review, both splinted and solitary anchorage were advocated, and maintenance were higher with solitary attachment. That because of the replacement or the need for frequent replacement of the attachment, but actually there's less biological complication there. So long maintenance care is essential for all type of design. This is actually another systematic review that came out of UNC. Dr. Anadiotti, who at the time was an implant fellow at UNC, she did a retrospective analysis looking and evaluating unsplinted implant maxillary overdenture. It was associated with a high implant and prosthetic survival, as well as patient satisfaction and improved quality of life. There was mucosal health and mandibular dental status resulted in significant differences among different patients to respect to their oral health and related quality of life. But generally, those are very well accepted prosthesis by the patient, resulting in improved quality of life and good functionality overall. So solitary attachment can work very, very well. So let's see some examples. And there's some of the cases that goes before the days of guided implant surgery or implant placement. In fact, actually, I saw this patient this afternoon in my practice. He's close to being 100 years old. And still see him, will still maintain his prosthesis and his mandibular teeth. He has a dentate mandibular teeth that we still maintain. But at the time, he needed a maxillary prosthesis. We spoke about four implant overdenture, palatless design supported with a metal framework. So we fabricate a denture, or at least we get to the tooth setup or wax denture step. We duplicate that and in acrylic and define exactly where we'd like to have the implants placed based on an or evaluation of 3D X-ray CBCT. So I make an impression, send it to the lab. The lab will fabricate a metal frame, and we'll send it with a wax trim so I can do my MMR. Notice here the extension with base plate wax just to give me a little bit more retention during that important step of MMR and tooth try-in. Here's the tooth try-in. These teeth were set up by our in-house lab technician at the time, Dario Zuniga. And then we have the tooth try-in is done, and we can proceed from there for processing the denture after evaluating static, vertical dimension of occlusion, all the parameters that we would like for these type of prosthesis. Notice the prosthesis was processed. I did not pick up the attachment or process the attachment inside the prosthesis. You certainly can do that. If you need to do that, then you have to place the abutments and use impression copings to impress them, have them in the cast so it can be processed. I like to pick those intraorally, especially with conventional prosthetics. You're gonna have some polymerization shrinkage, and sometimes there might be slight misfit. So I like to pick those intraorally, one at a time, to ensure full seating of the prosthesis. So I seat my prosthesis, check borders, check occlusion, make sure that it's fit passively, then pick up the attachment. So here's the prosthesis in place. Patient is happy, occlusion is good, vertical dimension is fine, and then we pick up the attachment. And this is a locator attachment from Zest, and we replace it by. So here's what I like to do with 4 implants. Sometimes it's very, very retentive that the patient will have hard time removing it. So normally what I do is I replace 2 of the attachment to start with, uh, leave the other 2 in just a processing insert till the patient gets used to it. Then I replace the other 2 so they're having less hard time removing and maintaining the prosthesis. Now, let's talk about unsplinted dental implants more. What's the advantage of those? It's simple, like you see, it's easier maintenance, easier cleaning for the patient. However, it's very, very important that we have parallelism of the various dental implants, and to ensure that obviously guided surgery and prosthetic planning is very, very key. It will also require less interarch space. Generally, it's less expensive, easier to clean and maintain, and result in very, very good satisfaction for the patient. We can also utilize that in the mandible. We discuss splinted versus unsplinted dental implants. Again, it's very, very similar to the maxilla. Both works, less maintenance with the bar overdenture as far as the replacement, the attachment. But generally, there are more soft tissue problems in the bar group and similar patient satisfaction. All of them with less space requirements with the unsplinted dental implants. So here's another example. Actually, this patient currently uh, left North Carolina. She resides in Colorado, maintained by one of my former residents there. This patient has a subperiosteal prosthesis that got infected. And so we had to remove it surgically. This is a picture from a different patient. I don't have that picture of that prosthesis after surgery. But you notice after healing, this patient had significantly a lot of bone loss that prevented even having initial dental implants without bone grafting. And obviously, a regular denture would be very, very challenging for her. You can notice the amount of bone loss, almost the inferior alveolar nerve is on the top of the dental arch. So this patient received actually a happy graft in conjunction with particular bone grafting. This was done by Dr. George Blakey, our chair of the Department of Surgical Care. Waited for healing, and then we had a cone beam CT that was done. You can evaluate and appreciate the amount of bone gain that we gain with the bone grafting, not only in vertical direction, but also horizontal direction. So now we can utilize dental implants anterior to the mental foramen. So we have a very, very limited area where we can utilize dental implants. And we discussed the option of actually doing a fixed prosthesis, but the decision was to go with removable on 3 implants. So we start with our processes here, make impressions, get to the MMR step, evaluate where the teeth needs to be placed, the lip support, the occlusal vertical dimension, the plane of occlusion, all of these parameters. And from there, we will have a tooth setup done, and we can do a tooth try-in. And at that stage now, we could duplicate this, fabricate surgical guides for the placement. This is another case where actually we did conventional surgical guide. Those were before the days of guided implant surgery that I will touch on a little bit later. So here's the duplicate, and based on the cone beam CT and our evaluation, again, we duplicate these dentures in radio opaque material, so I can now actually know exactly the position of the teeth and then relate that to the position of the implants. And we can go ahead and place the dental implants precisely where we need them to be. Notice the beautiful bone that we have now post grafting and post healing, and that's the placement of 3 implants. Those were Astratech implants from Dentsply. Um, this is right after the placement, and this is after second stage surgery. So at this stage, I already have my try-in. So the only thing I need to do is place the abutments intraorally. And notice here, I just open a window in my try-in to see it passively and just created a wash impression so I can pick up the attachment. And this is the process denture. And again, very similar to the previous case, I'm going to pick those intraorally and then convert them to the attachment with the retention that's acceptable for the patient. And here's the patient after the prosthesis is completed: a conventional maxillary denture and a mandibular implant overdenture. And the patient is happy. We're able to maintain her for years, and then she decided, she was living in Wilmington, North Carolina. She would drive about 3 hours to get to my practice at the school. And then she decided to move to be with her son in Colorado, and now she's being maintained there by one of our former residents. Now, bar overdentures, again, we utilize those particularly in cases we have severe bone resorption where we actually need some vertical support for the prosthesis. However, we will need more interarch space. We're talking about 12 to 14 millimeters versus the 10 millimeters or less that we can get by with the implant overdenture. You will need about 2 to 3 millimeter for soft tissue. You need about space about 2 millimeters below the bar. Then the thickness of the bar would be about a minimum 4 millimeters. Then, of course, the attachment, the housing, about 2 to 3 millimeters. And here's an example. This actually was done by one of our former students. We fabricate the prosthesis, we scan it, and we use that to actually design the bar for the patient. So it's, again, prosthetic driven planning and execution for the treatment. So here's the bar, and notice that this is a bar which with actually individual locator attachments used as the attachment mechanism. You can use different type of attachments: header bar, locators, even other type of attachments. And here's the processed prosthesis with actually the attachments processed inside the prosthesis. Then they are picked up in the prosthesis will be changed intraorally and can be picked up intraorally. You just have to be very, very careful, making sure that you block all the undercuts, the areas below the bar, so you don't have acrylic going underneath and locking the prosthesis in place. And we have a happy patient. Now, there are different type of attachments that can provide you similar retention to what you get with bars. Here's an example, which is a customized attachment system through Dentsply Sirona, for example. This is the CONUS concept. These can be customized, particularly in areas of misalignment of implants. It has a housing that's standardized. This type of the attachment from the margin to the top is pretty much standardized. What you could customize is the angulation and the connection to the implants available for all various and all major dental implant system. It has a total occlusive convergence about 5 degrees, which allow you to get parallelism, but also you can customize it for the patient. And then you can pick up the attachment intraorally in similar fashion to other type of attachments, such as the locator. So here is an example. Again, it's designed by digital planning. So we scan the prosthesis, we scan the patient, and then we can customize the position of the attachment to ensure parallelism of the attachments and the prosthesis. And you notice here that this implant, how it's angled, and we can correct the angulation to a certain degree by providing this type of attachment. These are placed intraorally, and then the overdenture is fabricated. Here is the inserts or the housings are placed in the mouth and then picked up intraorally and provide a very, very good retention for the patient. These are very, very retentive that some patients will have hard time removing them. Actually, they have special removal tool that the patient can use to remove this prosthesis. So here's a maxillary with overdenture on conus abutments done by my dear friend, Dr. Hobson-Berger, with a metal retention and metal framework. Here is a similar prosthesis done for the mandible. This was done by one of our former residents, Dr. Prudenti, done by Mr. also Lee Culp as far as the ceramic work. This is a prosthesis done in zirconia with a titanium support bar around the attachment to prevent any fracture of the prosthesis. It's pretty much what sometimes you do for hybrid prosthesis, except this is a removable prosthesis with attachment. So it provides you the retention, the stability, the functionality that a fixed prosthesis can provide, but still the patient can remove it and have better maintenance. So if you have a patient who you're worried about them maintaining their prosthesis, but they require, more retention and more functionality, and even if they have like ceramic teeth in the maxilla, you would like to have similar ceramic to ceramic contacts, you can fabricate this type of prosthesis for these patients. Let's delve into a little bit of digital workflows with overdenture. And a lot of the time, patient comes in, they have an existing overdenture that they have been using for a few years. They require a new one, and you definitely can follow like the duplicate denture protocol that you can use with regular dentures with implant overdentures. So what you need here is just making sure that you either duplicate the denture or use the existing denture, make a wash impression, have that scanned either by intraoral scanner or desktop scanner if you have an integrated lab with your practice or a close by lab. Now, if you duplicate the prosthesis, you scan it, you have 3D printed duplicate, you can send that to the lab and scan it there. So what you do is you get an upper impression, lower impression, and bite at the same time. You can do border molding and you can do impressions for the implants. Notice this patient have a 4 implant maxillary overdenture to implant mandibular overdenture. And from there, we actually scan that with intraoral scanning. Let me see if this video plays here that show you how we actually scan the denture. There are techniques of how you can utilize this. And once you capture that scan and the bite scan, all that information can be transferred to the lab from there. And of course, the lab then can use the existing denture as a foundation to establish a new design. You can actually select whatever teeth, shade, and mold you would like, or if you want to just copy the existing teeth, that can be also incorporated in the design, and the teeth can be either 3D printed or milled, and the denture base can also be milled or 3D printed. Now, this was a 3D printed denture, so this is the final digital design here for the prosthesis. This step is absolutely optional here, but of course, you always would like to verify that everything transferred well. You have good aesthetic, good functionality, evaluating the plane of occlusion. So you can have actually monolithic try-ins back from the lab. These also can be customized with pink material, pink composite, just to give it a more realistic look and evaluating the aesthetic. But again, if you trust your workflow, if you work with your lab technician very well, and the transfer of the data is very accurate, this step can be eliminated, and you can go directly to the final delivery. Now here, if let's say if you're not happy with the fit of the denture, you'd like to improve it, or you notice that there are slight adjustments needed for the bite, or you made any adjustments, you can go ahead and make another impression, take a new bite, and send that to be rescanned by the lab, and the design to be modified based on the information that you need now. And from there, you can have the final design for a prosthesis completed. So this is the final digital denture design. And then, these dentures can be printed or milled. So this is a carbon printer that actually we have one in-house, and we can use it to print denture using Lucitone digital print, which is one of the FDA approved denture resins that are available. And notice that's very hard with printed or milled dentures to actually process the attachments in. So those will have to be picked up intraorally. So we go from the final denture design to the printed dentures, both maxillary and mandibular. And this is after picking up the attachment intraorally. And we have a very happy patient that can receive denture or duplicate denture in 2 to 3 visits. Talking about patient-specific surgery or guided surgery, utilizing dental implants and guided surgery. This is very, very important because you could actually optimize the position of the implants, the depth, the angulation, but also the parallelism, which makes then the treatment with overdentures more predictable and more precise. So normally the workflow that we would like to utilize, we do something called a dual scan of the denture or dual scan protocol. So we get to either the try-in of the denture or a finally processed denture that the patient is utilizing, and we use the radiographic markers. Normally, you would like to have at least 6 to 7 markers that are widely distributed on the facial and the lingual aspect of the denture. Then the patient would have this denture scanned with the cone beam CT while they're wearing the denture. And also we have another scan of the denture outside the mouth. And then you go to a treatment planning software to plan the dental implants. Um, and you can marry those two together. So now you can have prosthetic planning for the dental implants, and you can plan the surgical guide. So in this case, you ensure parallelism, optimize the implant position, distribution, and location. And then from there, so similar to what you see here, you can plan where the denture is, you can plan the position of the implant, the angulation. You could even place the type of abutment you want, the attachments. You can work the spacing exactly what you'd like it to be. And there's a need sometimes to even do alveoloplasty. You can have what's called stackable guides, so multiple guides that can fit to the same base, where you can actually reduce the bond and place the dental implants. So you can see here the planning, and then finally we can have the final uh, plan of the guide, and then the guide can be either milled or printed. Mostly now we utilize dental printed guides. We will have titanium sleeves to guide us in the process. And a lot of these surgeries sometimes can go flapless, but sometimes you could flap the area if you, again, through the planning, you notice that actually bone grafting is needed, or you would like just to have a more careful placement to ensure that the implant's in the correct location, and if any adjustment for the plan is needed, can be done. So in this case, for example, we flap the area, place the implants that we would like, and in this case, patients received 7 implants, and in this, we can actually reline over these implants right after their surgery if the implants are stable, and we have the option of immediate loading. Then we can proceed with immediate loading and conversion that day, or even now. Nowadays, you could scan or do photogrammetry and have a prosthesis fabricated or printed for next day delivery, which is another workflow that's currently available and very, very prevalent in implant dentistry. Let's also talk about some of the available materials. Obviously, with overdentures, because of the presence of the attachment, sometimes the conventionally fabricated dentures can be a little bit weakened, and some of the complications you may have is chipping of the teeth, fracture of the teeth, fracture of the prosthesis. Nowadays, we have monolithic materials available in the denture workflows, particularly with milled restorations, but also it can be further improved and strengthening with like 3D printed mesh frameworks that are available. Those are available. For example, this is Evident. I will show you here the denture design, but also a 3D printed mesh support around the attachment that can be incorporated within the printed dentures for further support, minimizing some of the complications you may have with these type of prosthetics. Uh, that is utilized for the patient. So here in this case, we can see how this mesh is working on the attachment. You can even extend it over the attachment for further support. And again, that can be incorporated very, very easily with milled dentures. You can also utilize intraoral scanning with these type of prosthetics. Notice here, either you can use scan bodies that to capture the position of the implants. It's very, very important for the spacing. Um, if I'm picking those attachments and not processing them in, or not having the lab actually attaching those implants, sometimes I just put the housing insert here and I scan with that in place. Uh, then ask the lab to actually 3D print the model, process to that, or 3D print to that. If it's 3D printed fully digital fabrication, then I just need the spacing to ensure that I have the space to pick up the attachments, and then I will pick up those attachments intraorally, save myself the use of scan bodies, if you will. So here's actually a patient that I treated. This patient received 7 implants, 4 in the maxilla, 3 in the mandible. Implants were placed with guided surgery. I did prosthetic treatment, surgical treatment, and the planning for this patient start to finish. So again, my preferred design, 3 implant in the mandible, 4 implants in the maxilla. Here is the final impressions. Again, can be done with digital impressions, but I still like to do conventional because I can do border molding. So it's more dynamic versus static impression. From there, utilize exocad with my lab to fabricate strengthening framework for the denture. And from there, we can actually apply teeth and have a nice try-in then the prosthesis can be fabricated and the attachments will be picked up intraoperatively. Very, very retentive patients, very, very happy. And of course, again, very good functionality, very good aesthetic, and generally they are less expensive than if you utilize fixed hybrid in this case, which again is very, very possible for these patients and can result in a very, very good outcome. But actually, these prostheses provide a lot of advantages, nicer lip support, nicer aesthetic because you have that flange, particularly for the patient, so that the lips doesn't get sucked in. And they are, again, for the patient that you're worried about long-term maintenance with them, these are much easier to maintain, and we have a very, very happy patient here. So as I close this talk, let's talk about a little bit of summary of the success and complication with these type of prostheses. Normal implant survival, that's very, very good for this patient, particularly in the mandible, anywhere between 95 to 100% success rate. That number is lower to 80 to 95% in the maxilla. Again, a lot of factors involved, what you have in the opposing arch, health of the patient, quality of the bone, number of implants, distribution, the type of um, attachment mechanism you're using. Prosthesis survival generally very high, again, more than 90% in the mandible, about 85 to 90% in the maxilla. Some of the complications mostly would be attachment wear, both maxilla and the mandible, but particularly in the mandible. In the maxilla, it might be fracture or failure with the prosthesis, but also with implants. If less than 4 implants are placed, particularly with the 2-implant overdenture, there are more biological and mechanical complications. It's higher in the maxilla than the mandible. Biological risk, it's very moderate in the mandible, higher in the maxilla, particularly bone loss and preimplantitis. So it's very essential that you see these patients for common maintenance, common recall, regular recall, and check on these dental implants. But they need to be maintained. They need to be maintained very, very well with a very rigorous maintenance program. Otherwise, you may run into some problems, particularly in the maxilla. Patient satisfaction is high for both. Of course, it declines over time because of the loss of retention. So it's very important to talk to the patient about what maintenance protocol is needed, replacement of the attachment, but even in some cases, replacement of the abutment and the retentive mechanism there because it can wear out over time. So with that, my conclusion would be edentulism is and will continue to be a worldwide problem. There'll be a lot of patients who needs our help, and this will be a fantastic treatment and help for them. Implants options for edentulous patients are considered now the standard of care. Certainly can improve the quality of life for these patients. But like everything else in dentistry, it's very, very important that we have a very careful, detailed diagnosis, treatment planning, take the time to actually build the right plan for the patient. And evolving technology is very, very exciting. The materials are much stronger, they are better, result in better outcomes, and will enhance the treatment outcomes for the patients. So with that, I thank you so much for your time, for the opportunity to present this lecture for you. Be happy to answer any questions. And looking forward for future presentation discussing other therapies, particularly implant therapies.